We are living through a moment where whether it's healthcare is being rewritten, everything that we know is being rewritten, not just by medicine or machines, but by something far more invisible, the codes. Algorithm that can see patterns that we miss, systems that have never gotten trialed, intelligence that doesn't need a hospital building to change an outcome. But when you start asking technology to help decide who get escalated, where we get treated, and what get missed, you're just not building products anymore. You're reshaping power. My guest today is Dwayne Boyes, the CEO of MedTech, an AI group at the front edge of this shift, building technology, designed to support clinicians to make faster, sharper, and more equitable decisions in the moment that matters most. This isn't a conversation just about gadget. It's about what happens when intelligence itself becomes one of the most powerful assets in healthcare. Dwayne, welcome to Human Edge podcast. How are you?
Good. Anastasia, whakalofalahi atu, kia ora, bula vinaka. It's my absolute pleasure to be here and talk with you. And I'm really looking forward to sharing how we're going about solving exactly the points that you've brought up.
Lovely. I am excited about this conversation. Just before we were talking about we are at edge of the shift. Very exciting moment, very scary moment for some. Talk to us about what Meditech and AI Group are all about.
Great. So I'm the CEO of Dr. Sophia AI, which is a software as a service AI group. But a big difference between us is we actually started as a medical clinic. So the group started as Botanical Clinics Australia. So we had been prescribing medicine for 2, 3 years. And then additionally, we're a pharmaceutical group producing Schedule 4, Schedule 8 drugs. Now, the reason that's relevant is a big difference in how we go about the provision of healthcare is we haven't come in from a tech background. We haven't come in being, okay, we've done software and programming and we can see an opportunity. We actually come in as a group of people who care about others, come from deep Indigenous and ethnic backgrounds. And my exec team, I think we are, of the top six, five of us are non-Caucasian. So, you talk about, well, what does Indigenous and tribal upbringing and culture and community bring? That's actually the lens we're putting on AI. So the way we're actually approaching this is care first, equity, and what we're looking to bring in is actually a universal healthcare model where every Australian, irrespective of wealth, ethnicity, or location, can access primary healthcare. And we're looking to commercialize it so they don't pay a cost. And this has been our past 2 years of blood, sweat, and tears. And we're getting so close to actually rolling out the first iteration of that in country.
Amazing. Really excited to hear about that. But before we delve really deep into that and we talk about what you're really building, I want to sit in this discomfort for a second. What is broken about how we currently diagnose, escalate, and treat that most people never see, but you can't unsee anymore? What is broken?
Yeah, it's a really emotive answer, and I'll answer you with honesty.
Hmm.
So in Australia, we have an excellent situation, well funded, a reasonable to excellent level of facilities. But nonetheless, we have ramping crises in Western Australia where emergency rooms are overloaded, patients can't get off the ambulance, and their doctor's inability to see patients mean the critical ones don't get seen. And in some cases, it's actually led to fatalities. And in the emergency room scenario, something like 70% of all presentations are non admissions. So the very first thing to go, well, jeepers, what's broken is the system doesn't have the throughput to give the qualified level of care to all patients. And because you can't give partway care, right? You can't go, okay, you have been assessed informally. You probably don't need to see a doctor. You go. Every single patient must go through, I'm APRA registered. Here's the appropriate terms for my information. Now I've been assessed. And enforcing that system, because that's what keeps people alive, quite painfully is actually causing the bottlenecks. And we just don't have the resources in the current system to break that. And what that is translating to, and we're an excellent case, right? The problem we have doesn't even compare to what we were looking at in the Middle East and in continental Africa, which I hope we'll talk about in a bit. But
Mm.
the problem is that so long as we enforce the system that says the only way we can make a call on you, these are the checks to make, we are tracking to a shortage of 10,000 GPs by 2031, according to the Australian Medical Association, ramping crises and just massive overloading and peaks and troughs. So the thing that is broken is that a system that worked for us at a given resource level is not allowing and is not expanding to deal with the level of care for a higher population base, but it's not easily integrating technology. And the real world outcome is people that don't need to get hurt or be harmed are. And so we're trying to alleviate that bottleneck.
You talk about bottleneck and technology, and I feel, and I know we are in a better place, but I feel like Australia, we are still behind. I came to Australia 2007, and I was
Mm,
coming from Finland. And what we are trying to achieve now is what we were doing back then.
yeah.
I mean, I come from a healthcare background. I've never seen, through training and all, we never used paper. It was all
Mm.
computerized, it was all in tech. And I walked here and I'm like, this, and it was a big thing that we are moving from paper to
Online.
everything
Wow.
computer. I'm
Hello
like,
2000s. Yeah, I know. Hello 2000s technology. Good to see you.
so it's interesting you say that. And I've also worked with indigenous population, and sometimes, as we say, like I hear it in WA, we may not have enough GP, but I also feel like in a well-developed country, we still have a population that is quite marginalized and still not getting access as they should be getting. So, what is Meditech, Dr. Sophia? What is Dr. Sophia promising to do? How do we change all this?
Okay, so I'll put it in a really dispassionate way, but then associate that to the human outcome. So the problem we have, and I'll go back to that emergency room example,
Mm,
is we need to get an assessment and we need to be able to engage with a patient when they need care, and they need to go through the system which says, okay, we can trust this information, whether it's heart rate, respiratory vitals, electronic health record. We can talk to you in a way that you understand, so English, indigenous dialects, Mandarin. And then a person who's qualified or a system that's qualified can go, hey, Anastasia's in trouble. She needs to see a doctor. Dwayne's just got a bad cold. Here's some ready pred. This will help you breathe. You go home. And so that part that we've just described is actually a data handling part. It's nothing to do with the care of professionals or the quality of outcome. It's just the basic ability to go, um, key stats, health stats are verified, key health backgrounds verified, the appropriate knowledge assessment is done, and now we're making a medical call, which may have a safety of life implication, and we're giving that to patients. And so, gosh, it's been nearly 2 years now. My background, I'm the software architect. I'm one of two IP owners for our entire system. The other is our CTO, Willie Prosek. So I've designed all of the way the system functions. 2 years ago, we answered every single technical question to do exactly what I just detailed to you. So,
mm,
medical data sovereignty, Australian privacy principles, encryption, access within country, de-anonymized data, access to medi records. And so we had a system which does exactly what we've said, and we've had it for 2 years. But the problem is, and then this gets to where does that affect the marginalized society,
mm,
is in Australia, we have no regulation at all, no matter how compliant your system is, even though you can go, hey, these are the elements we need, there's no clinical trial to go, great. That AI in 10,000 scenarios was 99 point something percent accurate. Here's the safety guards. You can now do that and alleviate outcomes. So we've had this system and we are now commercializing it. We are the first in Australia as a software as a medical device AI clinician, and we're just hitting off the low hanging fruit. But putting it into the marginalized communities, we are rolling out multi language capabilities. if you don't speak English, man, your chance of having a meaningful interaction with a doctor is low. And if you're from an indigenous community like I am, and say perhaps you're more remote, there's no access for you at all. And then there's a whole bunch of discrimination or patient angst on going, well, look, this person's a native English speaker. They don't look like me. I feel really uncomfortable. I'm not feeling understood or seen. And so our further iteration of the project is to actually have the AI skinned in an ethnicity and speaking in a language that you know, but then delivering healthcare at the point of need. So the example is, if it was an emergency room scenario, the moment you need help, your avatar comes up, talks to you, whether in an indigenous dialect or Mandarin or English, gets the information and sends it away to be sent to the healthcare node or the hospital or the clinic. And so that's the system we've built. That's the system we're rolling out with limited capability in country. But that's the system we're working to get clinical data in some of the most scary, exciting, amazing places around the world, because the end outcome for us is that the simplicity of data handling is done. It's done at a cost that doesn't see the patient at all. It's less than rebates. But then equally, it gets people to where they need to go appropriately, whether that's a script for Ventolin and prednisone, or whether it's, hey, you jump the queue and you go straight into surgery. So that's what we've built, Anastasia, and that's the thing that is giving all my hair to fall out.
Sound amazing. Just one question. Is it multiracial, monocultural, or is it multicultural? Just a smart comment.
Yeah,
I don't want you to answer. It's the moment we are living in Australian politics, which is interesting. Lovely to hear. Was there a single patient story or data point or moment that moved this from an interesting idea into I have no choice but to build this for you?
yeah. There's three, if I'm honest.
Mm,
One is our son, who's nearly 4 years old, and he has chronic pneumonia, and he's had pneumonia for the better part of maybe a year and a half, 2 years, which is very bad. The other was one of our investment partners whose brother in law died at birth because of a failure of disclosure of medical information within a one hospital system. And then the third is an oncology patient who we are using our AI to attempt to establish a CAR T treatment program. Now, I won't go into the further details of those two, but each of those are live examples now that we're working to fix or have fixed. But
mm,
what I will talk about in depth is my son. And so, an example of our youngest boy is he's constantly been catching pneumonia, constantly having fluid in the lungs. And just last year here in Australia, excellent medical access, very good healthcare system. Caught another round of chest infection. It took 2 weeks to get a booking with our GP. And then when we got to the booking, she was 40 minutes late, spent 5 minutes with him, said, don't worry. The pneumonia persisted. He got progressively worse. We come back in a week and a half, 5 days to book, see the doctor, sends away for a viral swab. The swab determines a thing called walking pneumonia, which is then a viral and then a bacterial complication. And then he ends up getting prescribed a antibiotic by solution. We put all of this data into our AI, and within the space of a 7.5 minute conversation, our medical doctor recommended the exact same antibiotics, made determination that there was a prevalence of, I think it's called chlamydia pneumoniae, which was prevalent in the local community, and that this is a likely outcome. So if we had had that tool authorized, and remember, my
mm.
team had created this knowledge for a year and a bit,
Yeah.
my son would have been treated within a day and a half of getting the swab, feeding the results, and getting the outcome. But in that case, he had another 8.5 weeks with ongoing pneumonia. So the cases I'm working toward, they do go from trying to save a young man and a family man's life, trying to drive a clinical trial, but they also go all the way back to just going, if you just need the time to look at the details, to look at the particular outcome, and then order a script, that's not
Mm,
something that should take 2, 4, 6, 8 weeks. It can be done now with the tech we have to go, here's your lifetime medical history. Here's a test for intervention. Here's an outcome. Here's a script. And so on the human piece and on the small scale, we actually just deal with all of the frustrating and inefficient medical outcomes my family see. And we're like, okay, can the tool fix that? Yes, it can. Okay, what do we need to modify? Yeah, it's got that. And that's the 70-80% solution we're trying to fix because, equally, again, with my son's persistent pneumonia, we were in the emergency room months before that. 16-hour admission, constant treatments with Ventolin, ReadyPred, monitoring of O2 saturation. Equally, if we had a verified wearable, we could have seen his O2 saturation's good. We would have had the history, and we could have got that Ventolin and ReadyPred sent as an e-script. We didn't need to ideally take up an emergency room bed in pediatrics for 16 hours over a Saturday night till I think it was 3 in the morning on Sunday. If we could stay at home and our boy could get that at home and we could monitor his vitals, which is all the tech we have integrated now,
Mm.
that's a bed for some other kid who probably needs it more. So that's the system we're working to. That's the thing we're fighting our backsides off for.
Wow, how amazing. And it's great to know that it's not something we're dreaming about. It's actually here. You are really not trying to replace doctor. You're trying to reshape the environment they think in. What had to be true for you, for your design, so that clinicians feel more empowered, not more policed by AI? Because I know people are very skeptical still about
Mm.
AI. Mm,
Yeah, yeah. I think we must always be skeptical. The world we live in is a difficult place now, and arguably less secure than the one I grew up in,
mm,
40 odd years ago. But a key foundation of our entire model, and I'll actually refer to a recent speech by Jensen Huang, who's the CEO of NVIDIA.
mm,
But an absolute key to our model is that no medical practitioner loses their job. And from our forecasts, what we see is a complete change in the career model. So currently, medical practice is a pyramid. You've got extremely senior doctors, policy regulators, middle management, clinicians, nurse practitioners, and you get more as you go down. The way we actually see it is going from a pyramid model to an hourglass model, and so we'll take out middle management. The receptionist or the person who's taking notes or the nurse who's doing non-value add tasks, those will all
mm,
be automated with AI.
mm,
But we actually see over 130%, so 30% increase in workforce, because under our model of care, one human GP, instead of seeing 8 patients physically in a day, could see 100. And what will happen is the AI will do 90, 96, 92, and the
mm,
ones where they absolutely need time, they'll do in person. And then the doctor audits and verifies the ones to determine compliance of the AI. In the case of geriatrics or pediatrics, we can bring in people of a lower skill level, integrate to wearables, and have them talk through the base care outcomes that would be from a qualified caregiver. So the biggest thing in our model is, good health for me and you isn't I talk to my phone and it gives me stuff and it's ordered. It's actually time. It's actually
mm,
proper time. It's hands on. And so if we can automate all those cases where it's 2 in the morning, I don't want to see you, I just want to get a piece of medicine,
mm,
absolutely automate it. But then that means the doctor can have 1, 2, maybe 3 hours to see my mum because my mum's distressed because she's got maybe a potentially worsening case of dementia and she needs to have that higher care. So the model that we sit behind is enabling the physical part, giving more time to those that need it, and then automating out all the nebulous stuff like here's a prescription, here's a sick cert, here's a non-admissible case for ER. And that's an underpinning thing of us. There will be more in the healthcare sector delivering more to those that need it. And we will never be a case of, people are fired because it's cheaper to push it through a server.
I wish more people can hear that. And yeah, I do see where people are quite skeptical and quite fearful. The older generation that are like, what is this? What's going on? And the younger generation that doesn't actually know what to do. They're like,
Mm.
but am I going to be replaced? What do I do? But when AI systems influences clinical decision, it's no longer just a tool or tooling, it is power.
Yep.
How do you think about who really ultimately hold the power in the ecosystem
Yeah.
that you're
There's
building.
actually, no, no, there's actually really, you raise a beautiful connection here. So there's some great things about AI, like there
Mm,
genuinely are. And the great thing about AI is that it's effectively democratic. And
mm,
so what I mean is, you can't keep AI to you. If you're a big tech person, because the technology is so ubiquitous, the advancements in SLMs and edge infrastructure and the diversity of models, thank goodness it's not a case where we can go, hey, I've created an AI doctor. I hold all the AI infrastructure. You can't make your own, and you got to charge me the exact same as a human doctor, but I make all the profits because the beauty is, and I'll use us for example,
mm,
our core team is 6 people. And then we've got about 30 subcontractors that do stuff, humans. And then we have employed agents that range from 63 to 135, depending on what we're building. So our company is a whole bunch of AI agents that do stuff that are commercial facing and groups that we can use when we need, and then a small crew. And irrespective of how small we are literally looking to challenge the big Cerners, the electronic health records, the Millennium Health records, major hospitals, because we can access the tools like anyone else can access the tools. So if you're a big corporate, say I'm a big tech group and I'm offering an AI doctor, which is 99.99% accurate, it's $100 a go, a cheeky group like us with 6 people and 30 and some 90 odd agents, we can go, well, we've used the tools, built an Australian specific doctor. It's 98% accurate. And by the way, we'll charge you nothing. The Medicare rebate's what will pay for it. So the biggest thing on, and this is one of the good elements on AI, is if you're not ethical, you've got a crappy business model and you're greedy, this isn't a system that you can copyright and you can hold the keys to. And if you do that, customers can vote and go, well, actually, hey, here's another AI doctor. They've got compliance and they've got through and done it. And this is something I love, right? It's not something that can easily be hoarded. And so long as we don't see hoarding of AI models, and there is um, some recent happenings overseas where the most elite models are being held. But as long as the tools are around, it's going to be applied democratically, and we as patients we can vote. We as customers we can vote and go to the ones that align ethically and financially.
Australia said to be nanny state, and it's gonna be interesting to see how we play this with AI. But the
Mm,
giants out there, whether we're talking about America and China, who are on the race,
mm,
and they are competing to who gets there,
mm.
where does ethics and what the humans are feeling sit? You played
Yeah.
a lot with AI. Where do the ethical nature of this really sit?
Yeah, look, I'll talk on what I can control
Mm,
because that's a thing that I can handle, and
mm,
um, the other side is I don't want to frustrate people who might be much higher than me. But no, there is a really scary debate, right? There's a really scary debate, mass surveillance of population. There was a big blue between Anthropic and U.S. Government, and that debate must be handled, with a community voice. And I love some recent policy that I've seen flagged in both China and in the state of California.
mm,
And I don't know the veracity of this. I haven't seen the policy documents, but my understanding is there's a move to make it illegal to make people redundant for the sole factor that AI is cheaper. And I think that's brilliant. That's absolutely brilliant. And so long as there are entities that go, look, we don't want profit at any cost and we don't want power at any cost, those entities must have a strong enough voice and be at the table. Um, but then talking back to what I can control and what we have here in Australia, the ethics piece, it is key. And I go back to that democracy or democratization of the tool. If we propose we've got a great AI, it's super cheap, all these doctors got fired, all these humans who used to do care got fired, I think that's an extremely short plank to walk. because we need people. When you're in trouble, you need to see someone who will hold your hand, who will calm you and be there. And for us in medicine, and me being raised on marae, indigenously, as part of a Niuean tribe, like we didn't grow up, we grew up really poor. We didn't grow up going, hey, great, if I can take these 3 sandwiches, you'll be hungry, but I'll sell them and make more stuff. That's not our culture. And this is what I'm bringing in with my indigenous team of people, and it'll be in our product. And I think, well, I hope, irrespective of the financial outcomes, anything that is anti people, anti society, pro profits, pro gouging, I think will be met with a large backlash. And, you can go back through our corporate content right from day one. When, when we had no TGA approvals, we had nothing. I was signaling we want to bring healthcare for free. We want everyone to have a go at it. If you're poor, we want you to have healthcare. And this is our underpinning ethics and values. And I hope that is something that lets patients go, hey, I don't know you because I don't trust you, but I'll give you a go and actually see it for real life. So, but I am an optimist, Anastasia. I am glass half full. I will say that.
I'm not a Pollyanna. I do tend to be a bit, yeah, on the other side.
Mm,
If your system contributes to a missed escalation or a wrong call,
mm.
where do you personally believe the moral accountability sits? Is it with the clinician, with the company, with the regulator, or the code itself?
So there's very clear outlines within regulatory compliance, and to boil it down to a simple sense, for software as a medical device, you typically have three classes. Class one, when we're talking in an agentic medical knowledge, all
Mm,
the tool can do is take information, present it in a way so that a human can verify all of it, and so that is just to assist with a clinical decision. That's
mhm,
class one. Class 2B lets the tool take the information, summarize it, and make a recommendation. And at class 2B, a medical practitioner can go, yep, I'm happy with that recommendation. I don't need to review everything. Hit a button, here's an outcome. Class 3 allows a safety of life determination, and here's an automatic prescription or here's an automatic referral. Currently, we're at class one. And so, what class one means is we meet privacy requirements, data encryption, data stays within country. We bring in the references and we present that entire piece to a human. And the human
mm,
goes, got it, happy with that, calls up the patient, verifies, they make the call. So, in that case, if our tool makes an error, the onus is still on the clinician. Absolutely. From classes 2 and class 3 above, that's when it's absolutely on the tool. It's on the tool because any element where the information is taken away from the human, or in class 3 is completely independent, it's our responsibility as the software programmer, it's our responsibility as the vendor that our tool must meet a certain threshold. And so part of the discussion we're hoping kicks off in country, but we are going to foreign markets where the need is so high that we can bring over an Australian best practice and actually operate the tool. But part of the debate is to go, well, look, if a human GP takes this long, costs this much money, and is 60 to 80% accurate, but an AI is 98% accurate, this much faster and 17 cents versus $60, then we need to accept that. And if the policy allows, so long as it's verifiable to 98, 99% accurate, that's what it does. And our outcome, people will die. People must die. It's God's natural process. I will live and then I'll pass away. So our outcome isn't everyone lives forever and it never makes a mistake. Our outcome is to work with the regulator, define what good enough is, which we see as much better than the current system, immediately available, far far cheaper or no cost, and something in the high 90s accuracy. And that if it falls outside of that, that's just the best the tool can do. But I will say we're talking hypothetically because none of the regulation exists here. And for the opportunities we're using overseas, we're actually using full human oversight. So, so yeah, that's how we see it, and that's our voice in the debate. Hopefully, as the regulators come on board and catch up.
So let's talk about, you just talked about overseas, and you did talk about Middle East and Africa. First, the first question, what is different? And how are you going, or how are you seeing the technology closing the gap between the undeserving being able to access care with ease and just the rich being the only one that access care like it is right now?
Yeah, yeah. Look, I'll talk to just one of the most beautiful experiences we had last year, and one of the most terrifying. And I think there's not that many people in tech that truly have terrifying work stories. So what happened is we had got our AI doctor. Accuracy is excellent. We had solved all of the compliance sides, and we had a really good meeting with TGA. And at the end of that long meeting, they just said, "Hey, the regulations and clinical guidance and trials for an agentic doctor don't exist in country, and we can't obviously give you a time frame because it's also APRA. There's a whole bunch of med boards, and you can't comply the tool, even though you've shown all the stuff." And so we made the call to go, okay, do we look at an export market so that we can have the tool do something that makes our hearts proud, but then meets what would be a clinical trial here? So all of the compliance, data verifiability, explainable AI, immutable audit logs. Should we do that, and let's help some people along the way? And so we had an investment lead, a gentleman who's ethnic Syrian. And so, long story short, we were over in Saudi Arabia. We get the call from representatives of the Syrian government, and they're like, "Great, we've got these meetings for you. Can you guys fly into Damascus in 2 days' time? And let's meet one on one and show the technology." And so this is a Sunday night in Riyadh, and I'm looking at sending my team in where there were literally bombings, literally major bombings of the defense ministry right next to where we were going, and there were active conflicts because Damascus in Syria is a dangerous place. And I'm a Christian, so I prayed on it, and God's voice was, go, if you can help these people, go. And the city of Damascus is a popular place. And so we went in, and I have to say, Anastasia, one of the most beautiful things you can never imagine is old Damascus, is the churches there, the people. For everything the Syrian people have gone through, we met with articulate, intelligent doctors, heads of government, investment funds, and we got to a point where we were looking to roll out our AI as a triage assistant in an emergency hospital in central Damascus because there were no doctors at all. The war, they'd been killed, they'd fled. And so we had this wonderful opportunity. And then, unfortunately, the war in Iran kicked off and Lebanon got implicated. And then there were a whole bunch of refugees, and it became even too dangerous for us. But so my heart is with Syria, and I hope this video gets to some of those gentlemen who I won't
Yeah,
name.
yeah, yeah.
But I hope dearly, one, security stabilizes. Two, I will honor that commitment as soon as it's safe for us to go back. But what we're looking to do is port all of the health concerns, all of the best practice model from an Australian clinical trial, help thousands to tens of thousands of people who have no option, and then take that data back and then try to shape the debate back here in Australia, New Zealand, and in developed countries, and go, hey guys, 100% doctor verified, no risk to patient, here's all the compliance, 99.9% accurate, and a verified thing, the 17 cents per consult. Where are we on regulation? And so this is an avenue we're still pursuing, not in Syria currently. We now have some really wonderful opportunities across continental Africa. But if we can help, 100,000 people here and inform, X millions of people back here in Australia, that's something, I'm risking myself and the team for.
I wanted to ask that. I know you did say you're a Christian, and there's a drive that we get driven when we are people of faith. However, what is that drive? What is that thing that says, as scary as it is, we're going?
Mm. Yeah, well, look, I will say for Damascus, it was prayer. But for me, I spent 15 years in the military. My father is a D-Day veteran. He was at Juno Beach on D-Day, and
Mm,
my uncle was a decorated paratrooper, again, all in World War II. So I suppose service is in my blood. But there's a really fundamental piece. You can look any newspaper any day of the week, and there will be just heartbreaking articles. And so I was reading with a case in New Zealand, a whole bunch of newborn and infant fatalities because of lack of care and training and the ability to get to train midwives in rural New Zealand and in congested cities. There were ramping crises, and then there were people, overloading hospitals. And so if that's happening, and we've got a tool that my team and I are going hand on heart, and we can alleviate that, then it's cowardly of us to not go and do everything we can. So it's really just listening to that voice, Anastasia. And I think, the military and me, if there's two outcomes and one scares you, you got to go to the one that scares you. And so, this is living that, even though I'm, now 10 years, 12 years out of the military. So that's my motivation there.
Right. If you had to choose, would you rather technology made the average care better for millions, or the worst case, less dangerous for the most vulnerable? How does that tension show up in real decision making?
Well, it's our path is both. Our path
Mm,
is both, and there's part of me, because I am an optimist, but sometimes I get really cranky. I get really cranky, and one of the things that gets me cranky lately is we've had the technology to give healthcare to populations probably 5 years, 7 years. Honestly, we have. But the reason AI's not got there is that commercially there's a bigger drive to train cars, to build drones, to do chat models, and they're a lower regulatory, lower risk threshold, and they make money. And it's a really heartbreaking thing to see the amount of harm and issues in society when we go the base tech that we've created, that's existed 5 years ago. And if we were a big tech company, jeepers, I bet you I would have had clinical trials showing 99% accurate, since maybe 2017, 2018. And so the point is, it a solution like we've created can go to those who are in remote communities, those who don't look like the doctors they see, those who have no money, and it can go to the people that are in a busy, inner Perth urban environment. And where I am here in Adelaide, it's a really great spot, right in the city. But you get homeless people, and I can see the homeless people. A guy just outside the front office, dude's got a smartphone. He's got a smartphone, and the cost of tech is nothing. The cost of a plan is nothing. So if you can deploy mental health outcomes, counseling, anti-drug services to that homeless person's phone, all the way to my family and I in Henley Beach, same service, same AWS platform, scales to 1 million concurrent users. If you can do that, we can do both. And so our business model is to focus on universal healthcare. Like, hand on heart, as cliche as that sounds. So my answer is both, Anastasia. I pick both, and we just need to keep going and get the regulatory approval.
have you been to continental Africa? Have you been?
No, so this is very commercial and confident, so I
Mm,
can't give the full details.
mm,
But we have a very exciting opportunity to help a major program,
mm,
primarily in the HIV space, but then
mm.
also in the general practice space. And we are looking to increase by nearly 100% the patients they can see by automating the nurse flow. So where I traveled, where there were wars, I spent a whole bunch of time in the Middle East, a whole bunch of time around Asia Pacific. And so my military career traveled me to those parts. But Africa is a first. And gosh, if we haven't experienced anything like Syria, it's going to be hard. It's going to be real. But just the numbers we're trying to help, if we can get these terms agreed to, we'll nearly double HIV treatments, within the space of 3 to 8 weeks on rollout. So first time, hopefully. And we should know in a month or so if we're going over and if we can have agreement. So really excited, and we're doing things that makes the heart sing, and it is scary. Some of these countries are really unsafe, and there's an Ebola outbreak.
Mm.
And just sharing work stories, we
Yeah.
were in Damascus just after the major bombings from a certain nation in the center, and there
Mm.
were incursions and fatalities to the northeast of us. We were then in Riyadh just before the drone strikes and bombing there, and now we're looking like going to Africa around the Ebola outbreak. So look, you got to pray, Anastasia, right? Because there's a whole bunch of stuff you can't control. But if the outcome is this is what gets clinical data, which shapes decisions back here, and we help 100 people, 1,000 people, 10,000 people, then you know what, mate, you have your coffee, you get in your plane, and you go do the job.
I can't wait to be back here and really hear what is going on and what are the challenges you face in Africa. I I love to say when I'm talking to the Australian systems, most of the time we are trying to address governance and let's
Mm,
get this correct, let's get compliance and stuff. And I feel like back at home we fight constant leadership and corruption and all these things. So it will be
mm,
very, very interesting to hear what the uptake is, what's going on, and what the challenges are going to be, and the success stories. Because I believe if you speak to the right people, definitely there'll be some success stories. So I can't wait, and I would afterwards we'll talk. I think as you're talking, there are a few people in my head I'm thinking, oh, I should introduce, and I've actually interviewed them on the podcast, so I'll send you those podcasts and I should introduce you to them, because they're young doctors in the
mm,
continent, and they're trying to really reshape and bring technology and AI into it. And I think
mm.
having a chat with them wouldn't hurt to understand what's going, that mostly in the East Africa. So
Yeah,
I'll do those in production and see where you go from there, because I believe we can, there's so much potential. And as you
thanks,
said, I know you
Anastasia.
were talking about New Zealand and maternal death, but I can't tell you how many people, how many stories I hear every day. She went to give birth, she didn't come out. She went to give birth, and I'm
Mm,
like, that's just wrong.
mm.
So
Yeah,
it will be interesting.
and let's talk a really basic technical thing, but then talk what the implication is. The initial trial, not to belittle it, is so easy because the process is we either have state patients who are going to pick up a medicine, or we have private patients with the funds to get healthcare. And the process they go through is they'll often queue for hours. Then, when they come through, they get one receptionist, maybe a few. They then get the details, they take notes. Those notes are passed to a qualified health professional, and that health professional does a health function. So, the simple thing that our tool can do this, but to double the patient flow in Africa in this program, all it needs to do is go, hey, here's your information. Talk to me on what's happening to you. There's an AWS server. Our platform's is on AWS, so it can scale to 1 million concurrent users. Here's patient information. Here's a health record against their state identification. Turn up to the clinic. Here's all the key data the clinician, the nurse, or the doctor needs. So instead of queuing for hours, sitting in a room, going through that bottleneck, patients come up in real time when they've got a window, and the doctor's requirements, including note taking, SOAP note generation, prescription, all of that's handled by the tool. This is the easiest thing. But the real world outcome is busy nurses see 1,200 patients a month. This will push them up to 2,000 and reduce their work hours just by removing non-critical aspects. And so, that's the difference. And if we talk in developing countries with care to mothers, a, a really exciting but hard part we're on is we're training our AI to an SLM, which is a small language model. And
Mm.
what that means is hopefully we can get there by Christmas. All of the capability, our 99% accuracy in primary healthcare can now be on a tablet and a smart device with no internet, no big data warehouse, and we can send that out into remote communities. So part of our hope is to get to people. An entire village or an entire node close to villages can have the equivalent of a geriatric pediatric care GP. So, gosh, why wouldn't you, Anastasia? Why wouldn't you do everything you could to bring that to community?
Will be interesting. Let's see. I can't wait to be back here and see what the challenges are. I do know my people, and sometimes we can be very interesting. So,
Yeah, I guarantee one thing: it will be an interesting time, and it won't be easy. I guarantee that.
healthcare is famous for saying, yes, we need innovation, and then rejecting anything that actually changes behavior. We are notorious in healthcare. What has building the MedTech and AI group taught you about this psychological adaptation?
Yeah, it's hard. It's really hard because you're dealing with a club that's so fragmented. They're not unified, and so additionally they're very traditional, right? Like, here's your clinical trial, here's the process. Oh, there's no rules for it. Too bad, guys. But people are dying and people can't afford it, and 10,000 GPs, and that's just the reality of the system. And so the way we're trying to tackle it is to do something so powerfully good and so demonstrably compliant that there's no question other than to begrudgingly go, okay, well, how do we start making that work? But it's hard, and we wouldn't be going halfway around the world if we could help Australians now. But from what the regulations allow us to do, we can make healthcare cheaper and do languages and make it better. But the full capability, we either sit on our hands for 3 to 5 years and go bankrupt with all this money in AI that we can't use and watch the heartbreak stories, or we do something so disruptive and we verify that the regulatory community here and hopefully the public go, this needs to be looked at in Australia and New Zealand and the Pacific, because I'm Niuean Fijian, raised in New Zealand, and my family, my little boys have little Aussie accents. They're here in Adelaide, so we're just going to go for it. And you know what? If it doesn't work, if one of us get hurt or something, it's a worthy cause, and it's one we've put our heart and souls into.
I believe it's going to work. And I was listening to, he's American and I've forgotten his name, but he's been a predictor of technology. He's in his 80s. He's been a predictor of technology for a long time, and he actually get about 86% accuracy in where we're treading, where we're going, what's going to come. And he said some very scary things, like we are 36 months away from the total disruption that we're very scared of. But he also talked about 2032, that most people will be having our brain and our AI brain as wearables. And I'm like, huh? So
I agree.
We can't afford not to be fast foot forward. And Australia, again, is notorious for this, where we're a developed nation and we like to take I even think of simple things like working from home. It was such a debate until COVID hit, and overnight we can work from home. We seem to have not learned anything. Because we are too slow and we wait everybody else to have the leading edge, and then we're like, we follow.
Yeah. I got to be careful. When I was in the military, I was on a diplomatic mission to the Pacific Islands, and the press approached me, and I criticized the public leader as a uniformed person, and in the rank. And I said, well, actually, I didn't like this and this. It's on national radio, huge uproar. But fortunately, my military officers didn't listen to that Pacific Island channel, and none of my superiors found out, and I got a promotion. So look, I don't want to do the same here. But what I will say, for a long time, Australia's been the lucky country, and that's meant we haven't had to innovate. We've got some great exports. We can buy stuff. We can stimulate through big infrastructure projects. But the negative side is we're not agile. Compared to the brilliance in China, the integration in China, the social policies of Nordic countries, Australia's just levels behind. And it's because we haven't had to. And, what's the answer? I don't know. But I think the productivity, per capita, our ability to embrace technology, and the nation's ability to navigate this really disruptive period, I don't think we're well placed at all. I don't think we're well placed at all. And yeah, it's in that regard. I don't know how the country will fare, but our typical thing is let's do a big defense project. Let's do some big exports of primary minerals and that, and that's really, it's not supported. I think that
Yeah.
agility and economy. But hey, we love it here. Our kids have Aussie accents, so we got to do our bit. And maybe healthcare will be, the one where it's a bit more agile.
Who knows? Who knows? Imagine I walk in a typical clinic powered by your ecosystem 10 years from now.
Yeah.
If I don't see a single screen, what would feel different to me as a patient?
Oh, okay. So here's my big heart vision, and this is what I hope. Our entire model is home node hub, and so what that means is when you're at home and you need medical care, if it's appropriate, the tool will give it to you then. And so I've had blood works for the same things. I just need a renewal of a endocrine related script. You don't need to go to a doctor or a clinic to do that. So the only time a patient goes into a clinic or a hospital is because they need a detailed interaction with a human. And so my hope is when you're rocking into a clinic, it's actually the doctor's got anywhere from 30 minutes to 2 hours to be with you because a whole bunch of non-essential tasks are automated, and the service of medical care you get is the highest level. And that's because, and using what we've created, our AI knows your lifetime medical history. It links to wearables and has all of the live data that you can get on wearables. And so before you either see a human or you get an automated response, all of that clinical knowledge is there to go, hey, you've got polymetabolic ovarian syndrome. I'm aware of these complicating factors. How about we look at this? I need to examine you in this way and look at these parts. So I hope that the experience people get, white people, brown people, poor people, English people, Aboriginal people, is all that highest tier, that thing that a really wealthy person would get. The moment you go in the clinic, that's what you get because that doctor's got all of your stuff and all of your info. And if we can get there, that's a good time. That's a super good time. And the tech's there, Anastasia, the platforms are there, like the knowledge base and the compliance evidence is there. It's just actually having the regulator catch up. And I'll talk, why was I in Riyadh before Saudi? We were invited as official Australian delegates to Saudi Arabia. We met with the heads of their healthcare. We met with the heads of PIF, a $1 trillion sovereign fund, and they took us through their centralized health node, and it is awesome. Every patient exists. A whole bunch of data gathering on critical outcomes, performance times, service times, interconnected network, and they were just planting the seed of getting agentic care into that. But nations like Saudi, UAE, they're light years ahead of us. And for them, you've got your app, you've got all your bloods and everything online, everything's digital. A lot of primary healthcare is no cost. And that tech has been around for years. So I want to see that in country here so that when you go to get healthcare, you're not, and I'll go back to my son, 40 minutes late, you get 5 minutes, you're not really listened to, you get a suboptimal outcome. That can't happen under our system because that will go, hey, persistent pneumonia, potential outcome here, recommend these tests. And so that's my hope for the future, right? Anyone rocks in and they get that, gold class treatment because the tech does the rest of the stuff to ensure it.
I can't wait. And I believe in your vision, so I can't wait. I'm sure we'll be here talking about the success story. But we often talk about healthcare as if it's a neutral system.
Mm,
But listening to you, it's clear it's a living organism,
correct.
full of trade offs, blind spots, and quite acts of courage.
Mm,
What your work forces us to really see is that technology is no longer just a tool inside that organism. It's becoming
Correct.
part of its nervous system, really. The real question is not whether AI will be in the room. I think we've gone past that. It's whether the human in the room will be conscious enough and brave enough to lead it well.
Yeah.
Dwayne, if every healthcare minister, hospital CEO, and medical school dean in the world had to sit with one sentence from you about the future of AI in the healthcare, what would that sentence be?
Okay. So I recently presented at a conference here in Adelaide, and I made this statement. And this is a statement I'm going to try and compress into one sentence. AI will give us abundance or apocalypse, and the goodness or the negativity of AI is completely in our control. So take your positions, take your governance, and create it towards abundance because we control this. Full stop. That's my sentence.
Lovely. What a lovely place to stop. And I hope every a healthcare leader who listens to us, stops being scared about AI, but listens to that statement and wanna just make some changes, some real changes, particularly here in Australia, because we need to take it and we need to take it now, or we'll have to be borrowing technology from China and the US, which is really sad because we have the opportunity.
Correct.
What a
Correct.
pleasure it's been to host you. It's such a shame the hour goes so quick.
It has actually. It has. Yeah, I think that's a sign of a good debate. But no, from our side, Anastasia, I love the opportunity. It's always good to talk from the heart, and I hope we're having this debate in a year, and I'll be in my gilded big office, and people will be healthy and happy. That's the hope. Thank you so much.